My name is Stan Schroedove. I'm from the Central New Jersey Brain Tumor Support Group, and along with Al Masella from the Masella Foundation and the Monmouth and Ocean County Brain Tumor Support Group, we're putting on this conference. I'd like to introduce Dr. Mark Souweidane. He's a nationally recognized in pediatric neurosurgery with a strong focus in childhood brain tumors. He is regarded as a highly accomplished microneurosurgeon and expert endoscopic surgeon, and is a compassionate advocate to children. He received his undergraduate degrees from the University of Michigan before attending Wayne State University Medical School. His postgraduate residency included a general surgery internship at the University of Michigan Hospitals and a neurosurgery residency at New York University. He completed his training as Chief Clinical Fellow in Pediatric Neurosurgery at the Hospital for Sick Children in Toronto, Canada. He oversees a transitional laboratory focusing on improving methods for treating children with incurable brain tumors. His work is nationally regarded for the development of drug delivery techniques for childhood brain tumors that are not amenable to surgical removal. He is a principal investigator for clinical trials using a direct delivery as a novel therapeutic approach. He supplements his laboratory research with clinical projects, both independently and as a member of multi-institutional studies, including the Children's Oncology Group and the Pediatric Brain Tumor Consortium. He's board certified by the American Board of Neurological Surgery and the American Board of Pediatric Neurosurgical Surgery. He's a fellow of the American College of Surgeons and the American Academy of Pediatrics. He holds joint appointments at the Memorial Sloan Kettering Cancer Center and the Hospital for Special Surgery. He serves on the editorial board for Neurosurgery and Journal of Neurosurgery, Pediatrics. He serves as chairman of the Neurosurgery Committee of the Children's Oncology Group. And let's have a nice hand for Dr. Mark.
I find that if I introduced myself, I could have saved another 10 minutes of my presentation time, but thank you for the kind words. And really a heartfelt thanks to Al Musella for the invitation, not just to speak, but also for really paving the path and really creating an avenue for individuals like myself who have what we believe to be innovative approaches toward treating otherwise very hopeless conditions. So compliments to you, and thanks again for the invite. This won't be much of a surgical talk. That's what I do for a living, but this is more of a conceptual framework for pediatric neuro-oncology, a primer for the individual, and then hopefully an introduction into some of the more interesting avenues that we're currently traveling in the management of children with brain tumors today. And certainly I want this to be very informal with the group that's here. Ask questions along the way if you do have questions. A large part of this talk is really meant to stratify and show the difference between what happens in adult neuro-oncology and pediatric neuro-oncology. And I say this for several reasons. One is because it justifies my existence as a pediatric specialist, but the other is to guide the individual and or the family or anybody involved in the care of these children toward the rightful paths that these children have the hope of, or the best hope, of being optimized with regard to the care of their cancer and hopefully the return to normal functioning for the rest of their life. I've listed a number of parameters here which are distinctly different between the pediatric and the adult population. This is not limited to just these several bullet points. I'll highlight these throughout the talk, but again, I'll come back to this idea that adult neuro-oncology in no way, shape, or form equilibrates with pediatric neuro-oncology for reason after reason. And I'll go through some of these in a little bit more detail. First and foremost, and this is kind of the most unnerving thing from the standpoint of the neurosurgeon, which is always considered to be the gatekeeper of neuro-oncology in children, and that is the number of practicing pediatric neurosurgeons to take care of this burden is quite few relative to the number of children that need it. If you look at that, and these estimates are probably a little bit outdated, but the number of children in this country and the number of, if you will, most accomplished pediatric neurosurgeons that are asked to take care of them, there's a huge disparity And I've mentioned there within the American Society of Pediatric Neurosurgeons, which is kind of the elite academic group. It doesn't mean that general neurosurgeons can't take care of children, but those that really focus on the contemporary and the academic forefront of pediatric neurosurgery, there's a huge disparity between the need and the number here. If you take all of neurosurgeons in general, I think this was a AANS survey in 2006, only 1/5 of all neurosurgeons actually take call for pediatrics. So the chances are likely that when a kid hits the door with a fourth ventricular brain tumor and hydrocephalus, they're not going to meet a pediatric neurosurgeon. They're not going to have the mindset of what they should be doing right then and there. They can certainly take care of the hydrocephalus, certainly take care of the tumor. But as far as paving that optimal path, chances are it's not going to be instituted within the first several hours of diagnosis. Whittle that down into institutions, not just practitioners. So 5% of the hospitals in this country are designated children's hospitals. Designation is somewhat variable, but nevertheless, having the resources, the infrastructure to take care of kids relative to adults. We're really underserving the children in this country by far. What this amounts to is, I talked about optimal therapy, but another is the fact that many of these children who have these problems aren't diagnosed for several months, typically. And some of this is logical and some of it's expected. You know, you don't think that a child who's having vomiting, the first thing you think of is a posterior fossa brain tumor, no. But nevertheless, I think that the training and the attention towards certain symptoms, ocular disturbance, gait imbalance, are not necessarily jumped upon as quickly as they should be. And this is one estimate that I said approximately 7 months from the time of symptom onset to tumor diagnosis. And that's pretty much the norm in this country and most countries. So there is quite a bit delay, and that can equilibrate into disease progression, dissemination, and ultimate outcome for these children. So what this really boils down to is, because of the few numbers, the few practitioners, we need to work together. Working individually, having an ego, there's absolutely no role for it in pediatric neuro-oncology. You need the statistical analysis of dealing with large number of children to basically change the format of what we're doing, to look at differences, to improve on the way we're doing things. So the Children's Oncology Group, the Pediatric Brain Tumor Consortium, both of which I'm very heavily involved with. I serve as the chair for the COG Neurosurgery Committee and a representative member through Memorial for the Pediatric Brain Tumor Consortium, are extremely aggressive about this cooperative idea and putting patients on trial. And I'll come back to that idea about trials that are designated through some of these organizations that are really considered to be kind of some of the most elite and thought about trials that children have available to them once they're diagnosed with a brain tumor. And that's how I always tell parents how they might define and select between institution or individual. And it's not necessarily because those institutions have the ability, but it's the individuals that have access to the information that's coming through these that might help these children and their families choose the most appropriate therapeutic direction. I mentioned I'll do this comparison between adults and pediatrics several times throughout the talk. So if you look at these numbers alone, maybe 1/5 to 1/10 of the number of adults that you'll see with primary brain tumors we see in children. So that has a lot of implications with regard to the workforce that I talked about before. A large department of neurosurgery, might or might not make that investment in a pediatric subspecialist. Part of it's financial, part of it's based on need. But you can see there the number of cases per 100,000 person years in the country, if you use 19 as a cutoff, only 5 cases. That's really quite striking compared to about 20 cases in the adult population. So in a general sense, 2011, for which I have these statistics tabulated for, 4,100 new cases a year in this country. So that has huge implications when you go to funding agencies, when you go to the hospital for capital investment, when you want to recruit specialists that might integrate themselves into the care of these children. And touched upon in one of the earlier talks is this idea of the patient advocacy groups. I'll come back to this a lot, and I have full commitment toward that idea that patient advocacy groups like the Misella Foundation and other foundations we've worked with will change the format of these diseases more so than any other aspect, be it industry or be it governmental funding. Really the voice of the individual, the family, is extremely important here. So prevalence, not just the number of diagnoses that are made, but the number of children that are living with the disease, whether they be on treatment or off treatment, is quite staggering. So as I mentioned, there are 28,000 children in the U.S. that carry the diagnosis of brain tumor. cured on therapy at recurrence. That's a huge number. That's a huge number, but still somewhat dwarfed by, if you look at the adult population, over 500,000, 612,000 for that particular year. The other thing that is kind of a misconception, and it's somewhat structured by age, but more importantly by pathology, which also is closely associated with age, is the overall survival rate of these tumors. People think of children's brain tumors as being extremely abysmal. There's no hope for survival. That is so not the case. And if you look at primary brain tumors in adults versus children, so the glial or neuronal-based tumors, the outcome for children is far better. Even if the most cancerous tumors that we're talking about, there's great hope and expectation for survival. And so if you look at these statistics stratified based on age, the best comers are those less than the age of 19, 18 or 19. So our children have the best potential for cure at the time of diagnosis. Granted, the histologies, the pathologies, the genomic characterization of these tumors are far different, but nevertheless, we have, I think, excellent reason for hope when we see these children. So when we meet with a parent for the first time, and of course they're struck by the diagnosis and the news, I always tell them that even in the face of the most malignant phenotypes that we're talking about, we still have a realistic expectation of cure in this situation. So yes, buckle yourself in, but also know that there's light at the end of that tunnel. Mortality rates. Now this is interesting from the standpoint of looking and comparing ourselves to our other pediatric oncology colleagues. We do not as well by some accounts, but better than others. So if you look at CNS or central nervous system tumors, mortality rate overall versus something like ALL or AML, neuroblastoma, NB, it's embarrassing. It's embarrassing that we're not doing that well. I am so convinced that this is just an example of lack of knowledge, lack of initiative, lack of drive, lack of research going in the right direction, lack of funding. If you can cure cancer in one organ system, I'm strongly convinced that you can cure it in any organ system, irrespective of some of the problems and limitations we'll talk about. It's a matter of time, it's a matter of initiative, and I'm strongly committed to see that through with certain pediatric tumors that we'll talk about. Now, if you look at this pie chart for the trained individual, like many of you are, you see the word astrocytoma and think, well, that's really no different than the adult population. I've listed there pilocytic astrocytoma. And anytime somebody comes in the door with a diagnosis, be it based on histology or expectation based on a high-quality MR, knowing the exact histologic variant of an astrocytoma is so critical and so disparate between pediatric and adult populations. So a grade 1 World Health Organization type 1 astrocytoma or pilocytic astrocytoma, entirely different. So when I meet with a parent of a child, they've been diagnosed with an astrocytoma, they're going to go home and look up astrocytoma. Oh my gosh, there's no survivors. There's expectation of malignant transformation after about 5 to 8 years, et cetera, et cetera. It's a distinct entity. It should be separated from the idea of it being an astrocytoma, in my estimation. And every other disease that's listed up there, primitive neuroectodermal tumor, ependymoma, pituitary adenomas, craniopharyngiomas, germ cell tumors, some of these are so particularly characteristic of the of the pediatric population. And there really is little crossover. And yes, you'll see some variants, but when we see an adult diagnosed with a germ cell tumor, for instance, that patient usually comes to me for recommendations and treatment and workup rather than the adult counterparts because of the familiarity with this. So really it's not so much pediatric based on age, but pediatric based on pathology and tumor type. And you really almost have to break down these ideas of age, even though it's very disproportionate and heavily weighted towards certain categories and age groups. Again, what's different in the pediatric population is 5% of these kids will come to us with some genetic predisposition to cancer, be it CNS or otherwise. I've listed some of the common syndromes here, the most common that we are familiar with: neurofibromatosis type 1, neurofibromatosis type 2, tuberous sclerosis complex. Some of these others are somewhat more rare. The reason I list this is just because when these children are diagnosed or part of a family with a certain cancer predisposition, they come under our surveillance in a much different fashion, be it surveillance imaging, be it frequency by which they're supposed to see an ophthalmologist. Whatever the case may be, this puts them on our radar as far as somebody who demands attention in a different way than somebody who doesn't have one of these cancer predisposition syndromes. And it also defines what we're capable of doing or how we should manage certain tumors. So some of these children with these syndromes are exquisitely more sensitive to the ill effects of radiation therapy. So we take that out of the, if you will, the arena of treating them for their primary tumor. And some also define the behavior of these tumors much differently. So a child with a hypothalamic chiasmatic glioma, a low-grade astrocytoma with NF1, we will treat entirely different than somebody that doesn't have that. Not just with the exclusion of radiation therapy, but the indolent biological behavior of some of these tumors are so different than they are in the individual that doesn't have one of these syndromes. So the knowledge base here becomes extremely important. I would predict that many of these cytogenetic locations and genetic aberrations that we're seeing is going to expand this field precipitously with regard to predisposition to cancer. I fully think it's going to be on the horizon where part of the general well-being physical examination of children will probably include some element of a serum test or a biomarker for some of these predisposition syndromes. A long way in the future, but I think that's certainly the way the field is going. How else do we differ from our adult counterparts? The demand is made on us in a different way from the standpoint of the surgical management of these kids. So anatomically, the brain and spinal cord are affected in a much different fashion than they are with primary brain tumors in the adult population. If you look at this bar graph here on the far left, so congenital tumors that are basically defined at the time of birth, if you can believe that that even happens, and it does, and fortunately very infrequently. And then pediatric, namely less than the age of, or young children, less than the age of 18, you see those two center bars. Most of these tumors being what we call infratentorial. So when we think of the brain and we talk about the brain, that's usually the hemispheres, the big bilobed part of the brain. Infratentorial is contained within what's called the cerebellum in the brainstem, kind of here behind the ears and at the base of the skull. So the majority, overwhelming majority, about 2/3 to 3/4 of tumors we see in children are located in that arena. That has much different implications with regard to how the child's going to present, much different implications as far as what we need to be masters of with regard to the management of the anatomical and the microsurgical issues, and what we can get away with and what we can't with certain therapies versus the adult population. And this is just for primary tumors. This doesn't include metastatic tumors in the adult population, for instance. So vastly different, and a different methodology here with regard to driving home that point. This cross-section of the brain, this being in the inner hemispheric fissure, the nose would be somewhere over here, the eyes, this is the top of the head and the back of the head. So looking at that percentile with regard to anatomic definition, about 1/3 or more tumors located within the structure of the cerebellum and the fourth ventricle. Importantly, because this is a very critical structure from the standpoint of fluid or CSF that egresses through the ventricular compartment out, the most common presentation for these children are blockage of CSF or something called hydrocephalus. Very early, the signs can be somewhat nebulous and very poorly defined. Irritability, nausea, vomiting, all the things that a kid gets with otitis media or upper respiratory tract infection or gastrointestinal disorder, et cetera, et cetera. The midline structures surrounding the third ventricle, the hypothalamus, the optic chiasm, again, about 1/3 to 1/5 of all tumors located in that region in children. The hemispheres themselves, almost equivalent or a little bit less as far as the overall percentages. So cortical tumors, gliomas, what you heard about most of the morning, less frequent in the childhood population. Certainly we see them, but a lot less frequently. And if we do see them, the histology is quite markedly different. I mentioned pilocytic astrocytoma. There's a slew of other primary glial tumors in children. Pleomorphic xanthoastrocytomas being one, DNETs, dysembrioplastic neuroepithelial tumors. All these are exquisitely kind of defined by the pediatric age group and it's distinctly different from the primary malignant astrocytomas we see in adults. And I'll say a couple words about brainstem tumors, about 10% of all tumors in children affecting a very important structure called the brainstem, midbrain and lower. And I'll say a couple words about as we move on. What else is distinctly different, and this is vastly different, is the potential for spread. So at diagnosis, irrespective, low-grade tumor, highly malignant tumor, the oncologist, the neurosurgeon, the person caring for these children needs to think about whether or not this tumor is contained or not. For variable reasons, they have a much higher likelihood, compared with our adult colleagues, of having these tumor cells spread outside the central portion of this tumor into the subarachnoid spaces principally. We're not talking about spread through the bloodstream into the liver and the bone marrow like we see with some other systemic cancers, principally within the CSF chambers of the spinal or cranial subarachnoid space. And you can see some rates here at diagnosis, what we'd expect. And even for JPA, juvenile pilocytic astrocytoma, the most benign tumor that we end up dealing with, there's still about 5% of these children at presentation that'll have some form of dissemination. It doesn't necessarily predict a worse outcome, but nevertheless, we need to be aware of it. So this has a large implication with regard to when a child hits the door. If they're stable enough, again, I start pulling that trigger, thinking about the long-term management of that child's tumor or cancer. So they start getting investigations right then and there, spinal MRI scan, looking for dissemination of tumor. This becomes a little bit more problematic if you delay it till after surgery, till after treatment, because of some of the artifact associated with those issues. So that has implications with regard to the way we govern and diagnose these children. And certainly from the standpoint of the therapeutic impact of that. It's very, very rare, short of the most benign brain tumors we see, to ever take a child through therapy and not think about systemic treatment. Systemic, I'm talking about craniospinal axis from the brain and the spinal cord. So the most common primary cancer we see in children, medulloblastoma, no child is treated without some idea about treating something in addition to outside the primary site of the tumor, which is usually the cerebellum. So there's usually, almost in most cases, some therapeutic endeavor, be it chemotherapy or radiation therapy, to encompass these other areas that are at risk, and they really are at risk. So focal treatment falls apart in some of these diseases because of the potential for late or distant dissemination. As I mentioned before, the majority of these kids are presenting with something called hydrocephalus, and that's a blockage of fluid. Again, in this mid-sagittal MRI scan, this being the nose, the top of the head, the cerebellum, you see this large, what we call pineal region tumor. It's contrast enhancing, it's causing blockage of fluid, which should normally go from the lateral, from the third, then into the fourth ventricle. So a very common presentation for these children. Treatment of hydrocephalus is varied. It's somewhat practitioner dependent. It's somewhat dependent on where the tumor is located, age of the child. But by and large, most of this falls, in my estimation, into the removal of the blockage. So if you can safely take out that lesion and restore normal circulatory pathways, that's by far the most ideal way of doing this. When I was a resident at New York University 20 years ago, there was a big debate as to whether or not these children should get externalized ventricular drains put in at the time of diagnosis, or should they get shunted up front, let things quiet down, then take them to surgery. We've come a long way, and I'll talk about how we've transitioned our mindsets. But by far, if we can take out the lesion, that's the best treatment for these children. I'm dealing with a child right now the past 2 days with 2 shunt revisions who underwent very aggressive treatment at 3 months of age for a large tumor in a similar location. The child, by every account, looks great from the standpoint of disease control, but now we're dealing with the ill effects of shunting and shunt infections, et cetera. So we tend to try and avoid these at all costs. And then I'll talk a little bit about the impact that minimally invasive neurosurgery has had on the management of children with brain tumors, because that's a very enlightening and exciting arena. So if you can take out the lesion as demonstrated in this pineal region tumor, restore normal circulation, that's the best methodology for doing this, and we can do this in the overwhelming majority of times. So you can see there the incidence of needing some form of CSF diversion, shunt or ETV, endoscopic third ventriculostomy in children at diagnosis is highly variable. So some will say less than 10%, some will say up to 30-40% will need this up front. So it's really all over the place. I'm proud to say that I think on our hands, in my career thus far, we're probably hovering somewhere around 5 to 10% as far as kids that eventually require some form of CSF diversion. Lots of reasons for that. Some have looked at parameters or prognostic factors that might influence the need for this. You see some of these listed here. I don't want to go into this detail, but just suffice it to say that the treatment of hydrocephalus becomes extremely critical from the forefront of seeing these children. So some have advocated, as I mentioned, shunting up front. Some others, in this really sentinel article that came out of the Paris group, talked about doing this form of treatment called endoscopic third ventriculostomy with any newly diagnosed posterior fossa brain tumor in children. So they really laid the groundwork for saying that this might obviate the need for doing something down the road as far as need for shunt. However, what I always hearken back to is the fact that if you can avoid a secondary operation, maybe even be under the same general anesthesia, it still has some morbidity associated with it, you should avoid it at all costs if your need for shunting is very low to begin with. I want to say a couple words about biopsy. We've gotten so good with our neuroradiology colleagues with experience to kind of predict what type of tumor we're dealing with that it's rarely indicated that we ever just put a needle in something or go in with a small tumor forceps to get a sample. In general, if we have the ability to safely, and Dr. Brim was talking about the safe maximal resection of these tumors, if you have the potential of taking it out, by all means, that's what you want to do. These children, whether it be the most malignant or most benign tumor, are going to do better. It's not always possible. And I'll talk about some of these variances and some of these examples where we can't do it. So suffice it to say that if we can obtain a very aggressive resection safely, that's always going to be our recommendation. So a parent will always ask, is there a role for doing a biopsy before you say that we got to go do a craniotomy and take out this tumor? That's rarely the case.
How about the brainstem glioma?
Right there.
Okay.
We've rehearsed. But so the brainstem glioma. So there are some variants and some examples where absolutely not. There is no role for doing a maximal aggressive resection. You mentioned probably the pinnacle of that in pediatric neurosurgery, the diffuse intrinsic pontine glioma. You can look at this MRI scan and understand the clinical history and make the diagnosis. During the era of the cooperative group studies that were looking at this, there was kind of this moratorium to never put a needle in these because we're so good at making the diagnosis based on clinical presentation and MR. We're doing biopsies a little bit more frequently today for other reasons, but nevertheless, you know this diagnosis. Right? So no reason to subject that kid to a biopsy just from the standpoint of, again, if there's a good, qualified, experienced group that's making that assessment. There's nothing more, I think, rewarding, and this happens rarely, and it's happened a couple times in my career where a child comes to see me with this disease in hand. The parents have this diagnosis written down on a piece of paper, an MRI scan that looks very suggestive, but then you examine the child, find out they have cafe au lait spots, they've got neurofibromatosis type 1, and lo and behold, it's a hamartoma, and it's not a cancer that's going to kill their child in 12 months. So again, taking everything in context becomes extremely important, but biopsy not always indicated. This example of a child with basically a hypothalamic contrast-enhancing tumor mass with diabetes insipidus. Again, you should be thinking germ cell tumor. You do the appropriate diagnostic studies from the standpoint of serum or CSF analysis. You can establish the diagnosis in some of these cases. Don't need to do a biopsy. But again, where the kind of the aggregate clinical and radiographic information is nearly diagnostic. Craniopharyngioma, this is easy. Calcified concentric calcifications in the suprasellar cistern in a child who's got some stunted growth, you know the diagnosis. No need to subject them to a diagnostic endeavor, notwithstanding the question of surgery. And I mentioned the issue of neurofibromatosis and other neurocutaneous syndromes, which really helps you quite a bit with regard to establishing the diagnosis. 5-10 minutes, I want to talk about the 3 most common tumors we see in children, because that lays the groundwork as far as some of the approaches we're moving toward. I mentioned medulloblastoma before, kind of neck and neck with regard to pilocytic astrocytoma is the most common posterior fossa tumor we see in children. I don't want to go into great detail, but everybody always wants to know which children are at risk for these diseases. The response is always the same. It's children much like our own. It's children who are our neighbors, who are our classmates of our children. Walking, talking, brilliant, blonde-haired, blue-eyed, African-American, Latino, it doesn't make any difference. Everybody's at risk. And these are children who yesterday were normal. And this really slaps the parents in the face as far as I don't understand. I'd like to go back. I don't want to wake up again and have this diagnosis thrown at me. So everybody's at risk, and I don't want to go into all the details as far as the differentiating features of medulloblastoma. CT, rarely done today, but between CT and MR, you pretty much know that diagnosis. We've gotten extremely good with histopathology and looking at these under the microscope to define this as a medulloblastoma. However, what has differed to some degree is the upper echelons of neuropathology and now molecular characterization that I'll talk about. As I mentioned before, most of these tumors have the capacity to metastasize, so it behooves us to make sure that we stratify these patients appropriately. Who's at risk for late dissemination? Who's going to benefit from a higher dose of spinal irradiation, et cetera. And there's some nuances here that become extremely critical. You can't always do a lumbar puncture, so most of them are presenting with hydrocephalus, so to put a needle in the back is probably fraught with some potential risk. To do a CSF sampling within 3 days after surgery, some will say, well, just do it while they're in the hospital, you give them some sedation in the ICU. Problem is there's blood cells, there's tumor cells swimming around the CSF, so that becomes somewhat more problematic, and the risk of a contamination is real. So we tend to have certain parameters as far as how best to define that. Thank you very much. Same thing's true in doing the MRI scan of the spine, as I mentioned. So there are some parameters that we use to kind of get around this idea of false positives, because you certainly don't want to misinterpret the results. To put that child on therapy they might not need, or withhold therapy that they might benefit from, becomes problematic. And somewhere between 5 to 15% of kids are probably misrepresented as far as their risk stratification. So this is kind of what the playing field looks like as far as prognostic groups for medulloblastoma, age being a very strong predictor of outcome, M meaning metastatic stage becoming extremely important, GTR, gross total excision, so total tumor removal or not, and no anaplasia. Anaplasia meaning how the tumor looks under the microscope to the pathologist. In a different representation, standard risk and high risk looking here. And then there's a third category that's usually listed, and that's infantile medulloblastoma. This is where we are today. And several works that have been published over the past 5 years looking at the molecular characterization of these tumors. Almost blinded to the neuropathology, but now if you've got a medulloblastoma and it has this molecular characterization, we know that they have a better prognosis than not. So what's very exciting right now through the cooperative groups and some pilot studies is actually looking at children that we know, based on the molecular characterization, have an excellent prognosis. So can we withhold dose-reduced radiation therapy in a safe manner, since late-term effects is very important in pediatric cancer treatment? So this is where the field is going, medulloblastoma really being the first one, the first entree into this exciting area of genomic characterization and risk stratification. And I know that certainly ependymoma, even DIPG, diffuse intrinsic pontine glioma, now are kind of running neck and neck as far as trying to define these prognostic categories based on genomic characterization. So this is the thing that inspires me to spend my career on an incurable tumor, DIPG, and that is if I can look at my brethren who spend their career doing the research side and the clinical research side of medulloblastoma and have a 80+% success rate, cure rate at 5 years, disease-free interval at 5 years, and a highly malignant tumor. It looks under the microscope, highly mitotically active, necrosis, neovascularization. If they can cure the tumor, means to me that, again, that we put a lot of effort into that particular cancer. We need to not necessarily shift, but get a lot of people enthused about doing this for other tumors that are quote-unquote untreatable. So even when we find a medulloblastoma, as bad as that news is, comfort to the parent that we can still achieve success with a high degree of efficiency. Not always the case, so 80 is not 100. And there's still that 15 or 20% of children that are going to have a recurrence and succumb potentially from their disease. Then included in that discussion is not just the cure, and I'm going to come back to this idea of, it's not just the cure, but it's the return to normalcy and the expectation that they can go through the next 7 decades, 8 decades of their life with a normal degree of functioning. Becomes very problematic. JPA, this is the reason that a lot of us went into neurosurgery, pediatric neurosurgery. This is the disease we'd like, if we're going to be faced with a child with a brain tumor, to see. It's very similar as far as the age category, the gender predilection, but as I mentioned before, this is one of the most benign brain tumors we'll see, extremely indolent. Operated one yesterday, and our expectation is that these children will do well. Very classic as far as their presentation, whether they be in the posterior fossa or otherwise. The treatment here, surgical excision. So again, even though we interface with our oncology colleagues as far as surveillance monitoring, absent from the discussion is chemotherapy or radiation therapy in the overwhelming majority of cases. So this is certainly a pleasure to deal with, because the outcome can be so good with the gross total excision as demonstrated on that MRI scan. And we usually estimate that a 10-year recurrence rate is somewhere about 10%. So about 10% will come back, and we can treat with other forms of therapy or re-resection. Excuse me. I find this to be one of the most frustrating pediatric brain tumors that we're faced with, and this is one of the last specific ones I'll talk about in the posterior fossa, ependymoma. So if you look at this under the microscope, if you talk to Dr. Zagzag, who's here today, say it looks very benign, very bland, it's not mitotically very active, et cetera, et cetera. That is primarily because the fact that these tumors are extremely aggressive in their growth characteristics, wrapping around very critical structures. Even with aggressive resection, the recurrence rates are roughly 30 to 40%. So ependymoma becomes extremely frustrating, and at recurrence, I wouldn't say impossible, but very, very problematic to cure. I won't go into much more with regard to the idea, however, that surgery plays the most important role in curing this disease. A couple words about brainstem tumors. As I mentioned before, or made some mention of, you need to be very, very precise about the subcategory of brainstem tumors. A focal tumor is much, much different than a diffuse pontine glioma. Here's a focal tumor. We know that's going to be a low-grade tumor. The former, that's going to be a malignant tumor or dedifferentiated or malignant phenotype, for which there is no cure. In other forms of brainstem tumors really demands the expertise of somebody who deals with these and understands these nuances before the diagnosis is made. I won't go into much detail as far as surgery, but remember this slide as far as the incursion on the patient. This would be the top of the head. This patient's on their belly, left ear, right ear. Here's the base of the neck. Here's a kind of an ink drawing of the proposed form of bone removal to take out these tumors. This is the layer of tissue over the surface of the brain that's exposing the brain surface itself. This is fairly standard and routine for a pediatric neurosurgeon, but again, still a big violation for that individual. I'm not going to go into the differences here, but I will say that knowing how to get around, and Dr. Brem talked about going through fissures and through natural chambers of the brain, so important. And the more you can, or the more you can avoid and lack violation of tissue, the better. And there's very, very particular ways of doing that through the fourth ventricle where most of these tumors arise. Even as good as we are, look at this. In year 1994, a very experienced group in Vancouver, look at the worsening, if you will, rates for removal of some of these tumors. This is a very good group. I know them all personally. They're talented. They're very honest. So of this 102 patients, not insignificant as far as still. And that doesn't mean they're permanent deficits, but nevertheless, there's some worsening. And that's expected if you have to go through brain to get there. A lot has been made of the idea of posterior fossa mutism. This is a very hot topic, whether permanent, most of these being transient. The sole risk factor there is, again, limitations of what we can do. Involvement in the brainstem, certain structures of the brain that we can't go into. A couple of words about minimally invasive neurosurgery, because this is extremely exciting, the way it's, in my estimation, revolutionized what we can do for kids. So this is the idea of, again, minimizing that violation of tissue. We can do this for biopsy. We can do it for decompressing cysts. We can do this for actually taking out tumors. But there's a lot of appeal because most of these are very, very deeply seated tumors that otherwise would require major endeavors to get to. And all over the board for treating CSF issues with blockage or hydrocephalus, oncologic goals, all extremely, extremely advanced today. We've paved a path really as far as education and the development of a lot of these agents to do this. Here's an example thereof, and I won't go into much detail. This is a child that you know or sounds like they have a germ cell tumor at diagnosis. Very, very small tumor, no hydrocephalus. This would require a major undertaking to get tissue sampling in a standard or traditional methodology. This patient was actually scheduled for what's called a craniotomy at another institution. Parents learned about what we do, came to see us. These are some intraoperative pictures of a small tumor right down in the middle of the third ventricle. Getting a biopsy here. You establish the diagnosis. She needed no other surgery. She got radiation therapy, some chemotherapy. She's cured with about a 90% efficacy. So understanding these and how we're going to do this with minimally invasive approaches that we see here in one of our earlier publications, we can even go the full gamut of taking out some of these tumors through a 6mm portal. It's a tiny, tiny thing about the size of a yellow pen. This is an infant with a large third ventricular tumor, again, scheduled for a craniotomy somewhere else. Parents came to see us. I won't go into much of the detail here, but what you're looking at here is inside the ventricular system through a 2mm lens. 2 millimeters, smaller than about 1/8 of an inch. And we're using very, very small instruments to go into this tumor, really work around it with great efficiency. You can see this thing blocking that third ventricle, micro instruments here, and essentially just taking out this whole tumor through these very, very refined techniques, incision about this long. So quite dramatic, and certainly not in my training when I was a resident, pre and post-op, so quite dramatic. Last thing I want to say, if I can have 2 more minutes, is this kind of adventurous arena of the neurosurgeon playing an oncologist from the standpoint of drug delivery. You give systemic chemotherapy to a child, you knock out their bone marrow, you give them systemic radiation therapy or whole brain radiation therapy, you certainly interfere with their cognitive development. So getting therapeutic molecules into the brain is extremely problematic due to a protective mechanism, inborn protective mechanism of the brain. You can get around this blood-brain barrier, you can get high concentrations of a chemotherapeutic agent and avoid that systemic toxicity. That's extremely rewarding. You can also basically ignore all these things that we've ignored on the table or on the shelf as far as very effective chemotherapeutic agents because they're too big, they're not lipophilic, they won't get to the brain tumor, so we can't use them. That opens up a whole new arena for these adventurous agents that we would have normally given up on. I have focused the past 15 years of my career toward this concept of what's called convection-enhanced delivery or local delivery, putting these molecules directly in the site of interest and going after the tumor full throttle. This doesn't look like it's going to work, but one of the current studies that we have open right now is using these very, very highly technical means, putting these small catheters deep within these unresectable, incurable tumors, in this example here, what's called a DIPG, or diffuse intrinsic pontine glioma, and infusing the agent directly into it. Extremely, extremely well tolerated by these children, quite dramatic. It takes a huge amount of infrastructure. This is an example of after treatment on the first day after surgery. You can see this big light in the middle of the brainstem. That's a radioisotope that we've injected into the brainstem. Looks like it would be catastrophic given that anatomical location. This is Caitlin with her permission of her mother. Several days after surgery, you can see the incisional site there. But really, we've been extremely, extremely happy with the surgical and the morbidity issue that has been essentially absent to date. A lot of this preclinical work was actually funded by the Misella Foundation to get us from basically a bench 14 years ago to now the first translational project that we've started with DIPG. We're extremely enthusiastic about it. A lot of the world is interested in how we're being able to do this. These are examples, these are sequential time cuts here. Same section of the brainstem. This is our infusate, our infusate, our infusate. We can go to wider and wider and wider. And that's what we're doing currently on this phase 1 study of what we call dose escalation, encompassing as much of that brain tumor as we can. And some of the challenges for us is to basically do what our oncology brethren have done with pharmacokinetics, our radiation oncologists have done with dosimetry, to now apply this to what we do with direct delivery. This has been absent from the field in anybody who's ever done this thus far. So to say that local delivery hasn't worked in glioblastoma is really short-sighted. We need to first define how we're giving it, where we're giving it, what concentrations, to really build and provide the building blocks for future clinical studies. And this is really where we're putting our emphasis right now. Last thing I'll say, so we put all this effort into treating these kids. The sad part is they're coming back with secondary cancers at an ongoing and progressive rate. A lot of this work by Dr. Packer and his group at DC National, looking at the late effects years after. I'm not talking about the neurocognitive issues and the sexual maturation and the growth issues and the growth retardation. Secondary cancers. These kids come back with another secondary, either primary brain tumor or otherwise. And this is what these graphs look like. The longer you follow them, the more likely you're going to see it. So what can we say in closing? I have a role as a pediatric neurosurgeon. Anybody in a pediatric realm has a very specified role and a very critical role. And it's wrong, I think, to put these kids under the, if you will, the care of individuals who have spent a lifetime in adult oncology, because this is vastly, vastly different. So it requires that discipline and that specialization. Multi-institutional cooperation in pediatrics and some of these rare diseases, 200 DIPGs diagnosed in North America a year. You need that emphasis of cooperation here. Nothing's going to get you further than cooperating with our colleagues. So not just increased survival. I showed you examples of medulloblastoma, how good we are. We still need to make certain that they have good quality of life, that they're going to be able to marry and go to school and have their own children. And that is an extremely challenging endeavor. Minimally invasive neurosurgery, I've been asked many years ago when I first got into this endeavor about 1995 as far as minimally invasive neurosurgery. Is it standard of care? I'd always say it's state of the art. I don't think you can say it's standard of care. It's standard of care. And if you don't have the capacity, these kids deserve that same type of minimally invasive neurosurgery that anybody would have access to. Be warned, molecular genomic analysis, we are integrating this into real therapeutic trials today, both for brainstem tumors and otherwise. Drug delivery is becoming a very hot topic, whether it be intra-arterial or local therapy, becoming extremely, extremely powerful as far as what we can achieve as far as therapeutic indices in the brain. And we're trying to really define the parameters by which we do that. And if you're going to treat these children, they can't come off study, they're cured after 5 years. We need to basically continue to monitor them and survey them to make sure that they don't have problems in the future. So with that, I appreciate your attention. Again, I appreciate the invitation, Al, and I'll take any questions if you have any at this point in time. Thank you very much.
Which drug are you using for the CEA brainstem glioma?
For the convection-enhanced delivery for the brainstem gliomas, right now we're using what's called a radioimmunotherapeutic agent. It's a murine-based monoclonal antibody that's tagged to a radioisotope. That's currently what we're using. The trial that we're currently designing is basically a multi-agent and targeted therapy based on the molecular signature of the tumor. So
then you do have to do the biopsy.
For that particular trial, we'll have to do the biopsy first.
And can you do how safe is the biopsy?
So how safe is the biopsy? Thus far, in our hands, it's been fantastic, and I think for large centers that have a good experience in this, the transient morbidity hovers somewhere around 5 to 8%. Transient ocular disturbance or facial paresis. Knock on wood, no mortalities with large series in this day and age, so it's extremely safe. And I would strongly advocate that if there's a therapeutic direction you can take these kids, that shouldn't be a hindrance.
Okay, thank you.
Thank you very much. Yeah, appreciate it.